So, Assalamu alaikum, good morning, and good evening, everyone. Thank you for joining us for our last session for our Mastering Meta-Analysis course. It's been an incredible journey so far. I hope that it's been a productive learning experience for all of you. And I hope that all of you have been practicing what you learn in each session. That's very important because true learning happens with practice, not only just attending session. Before we begin, I would like to welcome Dr. Amir Lagari, who is the visionary behind this whole initiative, and Dr. Faizan Shahid, who is our speaker for today, our instructor. Dr. Faizan Shahid, he is a graduate of Rawalpindi Medical University. He's an active researcher. He has a lot of publications and citations under his belt. He's also a reviewer and an editor for multiple reputable journals. And he has won multiple awards for his oral and poster presentations. And he's also been invited as a speaker on multiple forums to talk about topics like research basics and USMLE journey. And I think that his achievement speaks volume about his expertise on the topic that he's going to talk about, which is bias and heterogeneity for today. And I would also like to welcome and thank Dr. Amir Lagari, an incredible person, a truly altruistic person who strongly believes in making education accessible for all. And he's been working for that on multiple fronts, including primary education, including female empowerment in education, setting up IT labs all across South Punjab, especially focusing on underprivileged children, making sure that they have access to good education, and also for medical students as well. This research course is a witness to that. So with that, I would like to give mic to Dr. Faizan Shahid, and I would like to request all of you to please keep yourself muted and keep your cameras off. Thank you. Dr. Faizan, the floor is yours.
Thank you so much, Dr. Atta, for the wonderful introduction. And once again, thank you so much to Dr. Amir for being the mastermind behind this series, and also to Dr. Marwa Khalid for being the chief organizer, and all of the other people who made this vision in its present form. Just give me 1 minute. Let me turn on the slides, and then I'll share my screen, and we'll begin with the whole meeting.
Noman, I think you're unmuted, so if you can mute yourself, or maybe the host can mute the student.
Yes, sir. Okay. I have muted him. Okay, so I hope my screen is visible to all of the people.
Yes, it is.
Thank you so much. That's great. Okay, so with the name of God Almighty, I would like to begin my presentation. My presentation is on the last topic of a systematic review or a meta-analysis, which is the risk of bias. So first of all, why is risk of bias important, and what is risk of bias? So basically you have 3 studies. The first study is a clinical trial. The second study is a okay, so basically the first study is a clinical trial, and you can see that how all of this shows all of the strong, or each and every step of a clinical trial, everything is done so robustly and everything is controlled. So obviously in this study it's a very low chance that things would happen due to a random effect or a random chance. But if you say a case report, now this is, you just had a simple case and you presented a case report and that's it. So see, there is no robust methodology, there is no analysis, there's nothing. So that is the main reason that we do a risk of bias. It will help us stratify on the basis of the best and the worst sort of studies. Now I will show you a quality of evidence pyramid. I'm pretty sure you guys must have seen this pyramid before in this series as well, because right on the top of this is a meta-analysis. So the first thing is a systematic review or a meta-analysis. The second is an RCT. The third is a cohort study. The fourth one is a case control, and the case series or the case reports are at the very last. The reason, as we go up a pyramid, as we go up this pyramid, the each and every step becomes more tightly controlled, more robustly analyzed, and with a better methodology. That is the main thing. Now, secondly, this is just an objective thing that stratifies the research. It can explain heterogeneity, etc., etc. It's just a objective thing. There is no proper, way to say that it's doing all of this, and there is no objective way. It's just subjective. That, for example, some studies maybe, I say that cohort studies are, in this example, the cohort studies are more robust for me. But there may be some other person who says that he would prefer case control studies. We both don't have any sort of proof or any sort of facts to second our opinion, which is why we have all of these different tools to basically assess all of them. Now, I told you the first point that it stratifies the research on the basis of methodology. But what if you are basically using a study, you are doing a meta-analysis, and on this meta-analysis you see that you're getting heterogeneity. The reason you are getting heterogeneity could be due to different in the outcome measurements, difference in the outcome definitions. I'm pretty sure in the last lecture you would have learned about heterogeneity and its causes and everything. But there's just one thing that I also want to show in this article. It's that we included a phase 2 trial and the others were retrospective studies, right? Now, of course, the phase 2 trial, his name is Desborough. If you see that it has the 9 by 9 scores, which means that it has very low heterogeneity. It has very low risk of bias. Now, of course, if a trial is going to be better, but see, in this whole scenario, the Feldman is on the left side. In this particular outcome, Desborough is on this line, which is good. Its results align with the rest of the studies. But as you can see that here, Desborough says that there is no effect, whereas all of the other studies are showing any sort of negative or positive effect. The reason is that those studies are not strong enough to see whether, or those studies have not controlled for the confounding factors or covariates such that they can produce an effect. And we see that those studies have significant findings, but the problem is that those findings are erroneous. ERRONEOUS, I think that's the spelling. Erroneous. These findings don't exist. The reality is this, which was obviously, like, when we combined all of them, it was in our meta-analysis as well, that the confidence interval shows that there is no effect. It's just due to the lack of robustness in these studies. This is something which is very, very important, especially if you are conducting a meta or a network meta on 15, 16 articles. Now, how do you stratify them on the basis of each and everything? It's going to take you months. You basically, the first thing that you do is you look for the robustness or the risk of bias. Those studies which have the highest risk of bias, and you would obviously tend to support their findings more as compared to those who have a higher risk of bias as compared to those who have a low risk of bias. The low risk of bias would obviously be the better one. And lastly, it can also it can also help in exploring all of the contradictions in literature. You see, the contradictions in all of the literature. For example, there is, if you see the online literature, this study by Feldman, this shows that the risk ratio of thrombotic events, which is a adverse event, is high in those who take the desmopressin. But all of those, Mengel and Summers, say that the risk is actually lower in the desmopressin group, which is, now we have got contradicting sides, right? And then we had our breakthrough study or Desborough, the final trial, which actually showed that all of these effects are just due to small sample size or other problems in the methodology. The main problem is that there is no specific effect. It just varies on case to case basis. These are the things which are explained by risk of bias. But now the most important thing, that how do we, how do we make risk of bias, or how do we calculate risk of bias? The thing with risk of bias is that I can have added like 10, 15 slides detailing each and every step, but that would have increased the cognitive load on the people. That would have given you information which is all of the extra information which you do not need to memorize, and it would have been added to the load. So I'm going to demonstrate each and everything to you. I feel like that's the main way. If you want to teach a skill, you demonstrate it to the participants. Now, the more important thing is to see which tool is used when. That is the most important thing, because if you use the wrong tool, then you are assessing the risk of bias in a wrong fashion. And if you assess the risk of bias in a wrong manner, then every conclusion that you draw from those results are going to be biased, or they are going to be wrong, because you have not assessed the risk of bias properly. For example, I use this tool for RCTs. Now, this tool is not made for RCTs, and there will be many questions in which I'll be dumbfounded because I just cannot answer the observational studies questions with a randomized control trial. But if by hook or by crook I do it, and then the results that I will present, they would be a misrepresentation of the reality. And thus, any conclusion that I draw from those risk of bias results would be wrong. And it's a very essential part of your systematic review and meta-analysis. I don't think there's any journal who would accept, any journal that would accept article which has no risk of bias in it, or risk of bias analysis in it. So we're going to start with the easiest tool, which is for case report. I didn't write it before because I didn't want you guys to be confused. Case series, etc. This is the JBI checklist, which is the easiest checklist. I'm just going to start from here, and then we're going to move up the, you can say that up the evidence pyramid, just to show you guys how we do for all of them. Now, this is the JBI checklist for case reports, and for case series, you just have to write JBI critical appraisal checklist for case series. These are peer-reviewed, evidence-based checklists, which can, help a lot. So these are but the problem with these is that they are very simple ones, and they don't have a lot of questions. When you're doing the risk of bias for a RCT or a clinical trial or a multi-center prospective cohort, of course you're going to need more questions to critically assess each and every part of the study. But in a case report or in a case series, there's like very little. So that's why, for example, I just opened this one for case report and the one for case series as well, just for comparison basis. I hope all of you know the difference between a case report and a case series, but just as a recap, the case series includes more than 3 or more than 2 case reports, and it's basically up to 10 or 12 depending on, a lot of people, they give different numbers or different values, but that's the main thing, that anywhere from 3 to 10 cases is a case series, which is this one, and 1 or 2 cases that would include a case report. Like, obviously case report is obviously singular now. So these are the questions for case reports, and these are the questions for case series. You see that automatically the right one has more questions. The reason being, of course, because it is a more robust design. Now, the case report comes at the bottom, then the case series. So that's why, as a example, I'm going to now open a case series. And I'm going to assess the risk of bias in front of you. For the case report, I'm just going to go it over a very casual way. First of all, they're asking about the demographics, then about the history, then the current clinical condition, or the presenting complaint, then diagnosis, intervention or treatments, any follow-up, adverse events during the treatment, and lastly, if the case report has a proper clinical lesson, which is very like common sense, because all of these parts, you need all of them to have a good case report. So this is nothing complex. This is nothing to go further into. I don't want, if you guys want, at the end of the session, we will, critically appraise our case report as well. But for now, to, save time and decrease the cognitive load, I'll just explain this and then we'll move on to the case series. The reason I'm doing this is because those of a case series are very, essentially similar to that of a case report, because both of them are very similar, uh, you know, uh, methodology, or, very similar articles. Now, first of all, was there a clear inclusion criteria? The reason this thing is new here is because we have more than one cases. So now we need a proper inclusion criteria. What you will do, first of all, is that you will read an abstract. See, we have these methods. Three patients who presented to emergency department with STEMI were started on cangrelor, which is a antiplatelet agent. And of course, let me first of all just give an introduction. Cangrelor is an antiplatelet agent which is used, and in place of the other antiplatelets. It's a new novel drug. It has, theoretically, it has said to have a good efficacy and a safer, profile of adverse events. So it's used in the acute ST elevation MI as a bridge to CABG, and that's it. Like, we are basically using it instead of dual antiplatelet therapy, and it's a mini case series. Now, we go to the methodology. For this question, we'll go to the methodology, and in the methodology, we will see that if they have given a proper, inclusion criteria for the patients. Now, as of now, I can see that the STEMI, and that's it. Like, they haven't given anything else except for the fact that they will be using patients of STEMI. Now, there may be people who would say this as, yes, it's an inclusion criteria, but it's not a criteria. It's just that we include people of STEMI, which is like understood thing considering the topic. And inclusion criteria would have been that they include people with STEMI who have been presenting for XYZ, hours or XYZ minutes of symptoms. You would give a range of the symptoms. Then they would also give some more, how do I put this, more detail on their cofactors or covariables. Or if they were not looking for any covariables, they would have mentioned that patients, we did not assess or we did not restrict any cofactors or covariables, etc., etc. Like, you have to mention the things. Since those were not mentioned, I would personally do it as a no. Okay, I would like edit it, and I would be basically like, you can either control B it. What I do is I bold it, or otherwise I just import it into a PDF, and then I just mark a tick here, because in Word it's hard to use the draw function. So I would just do a tick, small tick right here. Now, as for the unclear option, this is when you don't know what to do. I'll be very honest. This is when you don't know what to do, and not applicable means that when you're not, this thing is not applicable to your study. In this case, some people would argue that we should put unclear, because they did mention that they are presenting, they are using patients who presented with STEMI, but this is a necessity because it's in their topic, so they have to mention STEMI. They did not give any extra information. So I would do no. Some people would do unclear. This raises the main question that which one of us is correct, right? Like, is it no or is it unclear? The answer is both. Both of us are correct, because risk of bias is a very subjective thing. Of course, like, you can make tools to, sort of make it more objective, but there's a limit to which you can do. And this is one of the main problems with assessing risk of bias like this, and especially of such small studies, is because it's very much, dependent on the observer's bias. And in this case, for example, I do the risk of bias analysis a bit strictly, so I would have selected no, but most people would have also selected unclear. Okay. Then, was the condition measured in a standard reliable way for all participants included? And we go right here. Now, of course, we're going to go to all of these cases. The introduction, we know this is not going to be found in the introduction. We go to the cases, and then we will see that how did they measure, or how did they diagnose the, uh, you know, disease or STEMI. And we see that here we go. And ECG showed these, this, and this. So patient was given aspirin and some lingual nitroglycerin, etc., etc. Now, most obviously, an expert cardiologist would have a different opinion, but all of us are not expert cardiologists, and like, we don't, it's okay. It's okay. Some of us are, most of us are actually students, not some. Most of us are students, And so because it's a long and tedious process, so mostly the students do the risk of bias, and then they send the files over to expert or their supervisor, and they just review it from the a summary of it. So according to our books and according to our knowledge, this definition or this diagnosis is enough. So I would click on yes. Then we go ahead and we see valid methods was used for identification of condition for all participants. Okay. Now, you would say that what's the difference between this? In the case of cardiology, there isn't a big difference. But in some cases, for example, psychiatry, now this means that the measured in a standard, reliable way for all participants, and this shows that were valid methods used. Now, in this case, ECG is a very valid method, we all know. But in terms of psychiatry, there are questionnaires with 30, 40 questions. Now, if I use a DSM-4 manual right now, it would not be appropriate because we already have a DSM-5, which is the current guideline, which is the current standard. If I use a DSM-4, I'm using an old biased method. The reason there's a DSM-5 is a testament of the lack of, some things which were covered by DSM-4. Otherwise, why would there be a DSM-5? So if I do that, it will be a bias on my part. So that is what the difference between valid and invalid method is. The valid method shows that EKG is it's like obviously ECG or EKG is a valid method. So I'm gonna click yes. But if it was a psychiatry or behavior science or even neurological disease, Parkinson's, Alzheimer's, multiple sclerosis, everything we have questionnaires for them. Almost all of the chronic diseases we have questionnaires for them. So that's why this question exists. Then we have that this have consecutive inclusion of participants. Now this is something which is usually not given in most of these case reports. Consecutive means that did this case report include participants who came one after another. For example, a person came and we saw that they were eligible for Kangalore, we included them. Then the next person came and they were included. Then the next came and they were included. This is consecutive. I read this article beforehand, and if I start reading it now, it's gonna waste time. But the thing is that this article does not mention it. So if it does not mention it, we cannot like clearly say no, because it did not mention anything. The no shows that it clearly stated that there was no consecutive inclusion, but it did not state. So it will be unclear. Okay. And we will do all of these like in a similar fashion. I cannot do this whole with you because it's going to take like almost 40-45 minutes for this one thing to explain. So like due to lack of time, I obviously have to just give you an idea of these. Now, lastly, most of these appraisal tools, they have a specific guideline for the how to score them. But in this case, there isn't a proper guideline, as you can see. They have just given us the questions, their answers, and obviously this is the guide. If for example, if you cannot understand, let's say, if you cannot understand what they mean by clear reporting. Okay, if you cannot understand this one thing, clear reporting. So in this case, what you're gonna do is you're gonna go here and you're gonna read this sentence. The case series should clearly describe the participants' demographics and then their age, gender, education, geographic region, ethnicity, time period, education, etc. Now, in this case, we are only presented with age and gender. In this case, age, gender, and only the significant any cofactor. So one would might suggest that when we are using the this tool, and we say that was there clear reporting of clinical information, we should select no. And you would be right. No one will challenge you on that because these clinical information are not given. It's like it's right in front of the eyes of everyone. But there will be some people who will suggest that they have given the relevant information. For example, for the surgery of cabbage, the age and gender has significant role. Similarly, smoker status has significant role. They've also like given his medical history for congestive heart failure, paroxysmal AFib, etc., etc., and his history of AICD. So, in according to them, they have given all the relevant information that they should give, but they have not given this extra information, right? In once again, in such a case, both of the participants are right, because I'm not so sure that education or even to some extent geographical region would have a significant effect on this thing. So of course, most of the studies would not mention it. So in this case, instead of writing unclear, if you say yes, or if you say no, no one's gonna come at you, or no one's gonna very much how do I put it? No one's gonna raise a critique on you. And this is one of the main limitations of risk of bias, especially in such small studies. I'm sorry, but it just exists. There is no workaround for this. We cannot remove the human bias ever. We can only like mitigate it, which I do hope that there will be more checklists, and which will critically appraise the case series in a more robust manner. But other than that, there is no solution to this. Now, this case series specifically did not give us any, uh, you know, how do I put this, scoring criteria or any way to give allot marks or allot scores to all of these questions. Now, there are 10 questions in total, which are in front of us right here. The easiest way is to give 1 for yes, no, 0 for no, 0 for unclear. And if it's not applicable, you just skip it, right? So if, for example, this question was not applicable to our current case report, case series, just as a hypothetical situation. So instead of scoring from 10, I would have scored 9 from 9. And if it is applicable, I would score from 10. So once again, 1 score for this, 0 for both, and skip the question for this one. This is the whole thing about case series. And the case report is like essentially similar. So there's not like very much a big difference or very uh, things that I need to tell you about a case report. They're like essentially similar. The case report is the easiest. Of course, it takes the least amount of time. So yeah. Now we come on towards the observational studies. Let me show you guys. Now we are on this observation studies. There's another tool, NOS. I also want to show you guys this tool. So we'll start with this one because it's easy. This one is a Newcastle-Ottawa scale. And this whole tool has basically two parts. The first part is for the case control studies, okay? And the second part is for the cohort studies, because obviously there are like two types of main observational studies. But if your study is not a cohort or a case control, right? It's nothing. So what you will do then is that you will go to other tools, which I will tell you in a while. Also, another thing, like what do we do for cross-section studies, right? Of course, like cross-section studies, there are meta-analysis for cross-section studies as well. So what do I do that for them? Once again, JBI checklist. JBI checklist for cross-section studies, it will also include like 10, 12 questions. Very simple, very, easy. I'll go over this one because the cross-section one is actually like genuinely very easy. I think I must have downloaded it somewhere. See, only 8 questions, and here is the you know answers to how to solve them. But just as an example, if you want, in the end, we can do a whole with example. But this is the first thing is the criteria for inclusion, which I already told you. Secondly, the study subjects and setting were described in detail. Now you see, they have said that in detail. Now this detail word is subjective. Some things which are detailed enough for me might not be detailed enough for you. And it's a problem, but there is no solution because obviously like the human bias. Then we have the exposure measured in a valid and reliable way, the one that I told about, DSM-4 criteria and the DSM-5 criteria. Lastly, your objective standard criteria used for measurement of condition. And once again, like in those in the case series, I said that we used the the ST elevation in the leads. In the scene of DSM-4 criteria, we used the score. So same thing here. Standard criteria, standard score was used. Confounding factors were identified, not controlled, identified. We only have to identify in a case control, or sorry, in a cross-section studies. We do the controlling in case control or a cohort study, especially in a cohort. Now, were strategies to deal with confounding the factors stated? Usually they are not. If you unless you're doing a very good study, cross-section study, these things are not usually given. I'll actually show you a small example. Let me give you a small example. I just remember a small article of mine from 2023. Now, of course, this is like around 2 years earlier. I was just a beginner in research, so I didn't know of all of these things. First of all, inclusion criteria. Here we go. Never mind. Here we go. This is the exclusion criteria, and this is the inclusion criteria. So yes, we have the inclusion criteria in this one. Was the study subjects and setting described in detail? We have the details of the subjects here, and we also have the setting here. So yeah, yes. Why was the exposure measured in a valid and reliable state? So how do we do this? We pilot study was conducted on 30 subjects. See, we conducted a pilot study on 30 subjects to assess the internal consistency of the question. That is the main thing which you are looking in a validity is the internal consistency. Then we also collected the data by a mixed mode questionnaire, which was administered both online and in person. So we have given details and how we did that. So yes, it was measured in a valid and reliable way. Were objective standard criteria used for the measurement of condition? Now, this is something which is very, once again, objective. Oh, sorry, very subjective. Because in this study, we have made a questionnaire which was developed by us, which was used by us, and then we did a pilot study. Most people would say since we did a pilot study and the internal consistency was good, so it was valid, but it was not the standard criteria. And I would agree with them because for standard criteria, you need already well-established questionnaires which are verified by experts. Ours wasn't. So we did not use a standard criteria. Okay. Then confounding factors were found. The easiest way to find for confounding is that first of all, you search confounding. No, I am not finding any confounding, right? We only found confidence. Okay. Now no co-founders, no covariates, no matching, no control. This is actually in discussion. It's an introduction, so it's not a part of our methodology. Once again, this must be in discussion. Yes. So, no, we did not identify the cofactor. Maybe we would have, like, obviously you would need a full detailed read. But as for this part, no, we did not devise any strategy to deal with the confounders. Okay. And since this is a descriptive study, you can see this is a descriptive study. So this one is actually for analytical studies, and for descriptive studies, there's a separate one, but it's not very good. It's used for analytical studies. Now, of course, in a descriptive study, these things are not identified. So we will click no. Obviously, you can either skip these questions, but I don't think that's appropriate because obviously, we did not do it, and it is a bias on our part. So that's okay. Lastly, were outcome measured in a valid and reliable way? So yes, we had. I think if you read the whole methodology, we did mention how to. Yeah, descriptive analysis was applied. Mean, percentage of connected, chi-square, man, Whitney, you were applied, etc., etc. So yes, we did measure them appropriately. And lastly, appropriate statistical analysis used. Yes, it was used. So I think in this scenario, our case report would score a 5 or a 6, which is not too good, neither too bad. So, sorry, our cross-section study. That's how you would do for a CS study, cross-section study. Now, let's start with cohort studies. One thing is that the NOS manual or the NOS manual, this would show all of the answers of the questions, and this NOS Gen, this would have all of the questions. Now, how to download this? I showed you how to download the JBI checklist. Go here, search NOS scale risk of bias. This is the website OHRI. This is the Ottawa Hospital Research Institute. And in this, page, you can similarly download the manual in the Word on a PDF format, the scale in a Word on a PDF format. If you use a PDF format, I would recommend ticking the things, marking a small tick. And if it's Word, I think I would recommend you to simple bold it. Okay. Now, while we are doing this, the cohort studies, the first question is that it has three basically domains: the selection criteria or the selection bias, comparability criteria, comparability bias, and the outcome bias, or bias due to outcome, bias due to patient selection, and bias due to comparability. Similarly, selection, it has 4 questions. Comparability, it has 1 question, but obviously like it has 2 parts. So it has 2 mainly, its weightage is 2, and the exposure, it has 3 main parts, or the outcome, it has 3 main parts. Actually, yeah, the outcome, it has 3 main parts. Okay. If you, I think I should just show you an example as well. I'll once again go to my study, this one. Now, in this study, you see selection bias, comparability, and exposure or outcome. Because the exposure and outcome is, it's exposure in the this section, case control, and its outcome in the cohort section. So it's exposure or outcome. In this, meta-analysis we did, we include a phase 2 trial, and we basically used the Newcastle Ottawa scale for this one. Now, this is not recommended. You can do it because there has. I'm sorry, I'll be taking questions at the
Everybody,
end.
can you please mute yourself? I think it was Anam Ijaz. Can you please mute yourself?
Okay. So anyway, in this study, we did, we assessed the risk of bias of a trial using the Newcastle Ottawa scale. Now, it's not recommended, of course. It's always better to use a different scale, but we use this because there is precedent for doing this. There is precedent for using observational, scales to assess trials, which is obviously not a good thing to do. It incurs bias, which we also like mentioned in one of the limitations of our study right here. But we used it to, promote homogeneity, or to promote uniformity across the whole risk of bias thing of the study. Now, would I recommend it? Honestly, I would say that if it's only one study, just as like in our case, just go with it. Do not use a separate scale for only one study. It sticks out like a sore thumb. But if you have 3 studies of a certain study type, let's say trials, and you have 4 retrospective studies, then use different. Then definitely use different, tools. Now, as for this, the first thing in the cohort study is that, is the case definition adequate? Sorry. The patients selected, are they representative of the exposed cohort? Now, they've given us 4 very good examples. If it's like these above 2, we can, score 1 point. If it's not, we'll just remove it. We'll score them 0. Okay. Similarly, if in this case, they've given us also the things which can be, if they are reported, then we will basically score them, or we will put a score in their against their name. New table. Now, of course, in this, of course, in this table, I'm going to add a table, and the first row would always be the, heading row. So we have three of our domains, the fourth one for the overall, this one for study name and study here. And let's just say a 3 by 3. Okay. And then I'm going to write the name of all of these: comparability, outcome, and selection, and lastly the overall. Sorry. I'm just using abbreviations and then overall. Okay. Now in this study, what you can do is you can either add the stars like this, or you can write a number. Okay. And lastly, it's always good if you mention out of 4, out of 2, out of 3, like this. Okay. And let's now assess the risk of bias of a study live here in front of all of you. Okay. In this scenario, first of all, we're going to see if the patients or the people included are representatives of the exposed cohort. Okay. Now, in this case, first of all, our topic is the prospective observational cohort study of connected place versus altiplace. Now, since it's already written in the cohort, we know it's a cohort, but sometimes it's not written if it's a cohort or not. Then you would have to search here if it's a cohort or not. If not even written at that point, I'm going to go to methodology, and there's going to be a heading of the study design like this. In this, they have also already mentioned like patient cohort. So this one, observational open label sequential cohort registry comparing, etc., etc., etc. Now, where the people are truly representative of the average, people of the community. What we are looking for, routine clinical practice, and obviously like these are thrombolytics. So I'm looking for mainly the patients of acute ischemic stroke, which are present right here, right? So now I'm just going to go to this patients. I'm going to see what all of these patients are. The primary cohorts for comparison comprised of patients treated with IV thrombolytic for acute ischemic stroke at the 10 hospitals in Texas from XYZ to XYZ date. Now, I think that they are truly representative of the average people in the community. And like, obviously, if they're like truly representative, then I don't want to do the support. Now, in certain case, what would you think that the people would not be, like how would we basically remove this point, or how would we score 0 in such a article? So if they had mentioned that the primary cohort include for IV thrombolytic therapy, they had not mentioned acute ischemic stroke, or they would have just mentioned stroke, not stratified. Now, obviously, in the particular case of stroke, it's understood that you wouldn't give a thrombolytic to a person with hemorrhage unless you want to kill them. But there are certain studies in which it's not like that much appropriate or not that much, distinct. So that's the main reason. For example, if you are doing a research on depression in adolescents and you select a study samples and you forgot to mention the age. Now, how can you ascertain that the patient, and when you see at the study in the end, the average age is, let's say, 19 or 18 or 17. Now, what guarantee do you have that the patient included all were adolescents? You don't. A mean age of 17 could include with a confidence interval or a standard deviation of 15, 10, 12, anything. The study may have very well included patients who were 20, even 24, and then acknowledged it as a limitation or something, right? So in such cases, you would either select somewhat or you would select no description. But obviously they did give description to some extent, to you would click somewhat. Okay. Now this part, the selected group of users, are example nurses or volunteers, this is not applicable to normal studies. It's only in very specific scenarios. Mostly you would have a cohort that will be actually like truly representative of their um, patient population. Okay. Another example is that, for example, I'm writing that I'm using this in routine clinical practice, and the all of the students or all of the patients that I include in this patient, like they were all the patients from only the hospital who had come here. But if I include a very subtype of acute ischemic stroke, for example, if I include only the multi-drug resistant acute ischemic stroke or only the acute ischemic stroke due to AFib, now that would be a misrepresentation, and it would either be a somewhat, but I would obviously prefer to say that it would be a zero score. Why? Because we are mentioning here routine clinical practice. Now, of course, AFib is a risk factor for stroke, but not every patient with stroke has AFib. Some of them do. And if I include only people with AFib, it's going to be a misrepresentation of the routine clinical practice, and that is going to be a bias. See, that's how you select this. Now, of course, there's one point for the selection of the non-exposed cohort drawn from the same community. Now, of course, they have said that they just included patients and they use IV thrombolytics. So they used both of those thrombolytics on the similar patients. They did not stratify them on the basis of their outcome exposure. So in this case, it would be 1 point. Okay, what you can do is you can fill this side by side, but I would personally recommend that you fill it at the end. It will be easy. Obviously, don't forget to mention the name. This is, I think, WARACH, so that's Varach or Varach. And I think this one was published in 2022. Yeah, 2022. This is how you're going to fill the selection bias. I'm not going to fill the whole of the selection bias. This is actually a very good article. I'm pretty sure it's going to get a score of 7 or an 8. Anyways, ascertain of exposure, like the reason you do, how did you say that they had the exposure? For example, in this case, we are like giving them either a TKA or a TPA, and it's like in front of us. So obviously, this is like very good exposure, but usually if you're doing a chart review or if you're doing a structured proper interview which has a structure, which is a validated questionnaire, and then you interview them based on the questionnaire, then you will get a point. Otherwise, if it's just the patient self-reporting or you haven't described anything how you're going to measure the exposure, then obviously it's going to be 0. And lastly, the demonstration that outcome of interest was not present at the start of the study. This is not applicable in acute conditions like stroke, because obviously like you need acute management, and after acute management, then only you can assess the outcome. This is done in the chronic conditions. For example, if I'm assessing the effect of on the, let's say, bradykinesia in Parkinson disease. Now, bradykinesia is obviously present at the start of the study. It is. And then when I give them the treatment and then I again see the bradykinesia, I would be like checking for difference in the bradykinesia. In that case, if I use a proper structured questionnaire, then only then I would be having a point here. Otherwise, I would not be having a point. And lastly, because since the outcome was present, I will be having a no, unfortunately. Okay. The only thing that it can be a yes is because if the sorry, I'll be selecting yes here. I'll be selecting a yes here, not a no. Okay, so that's the one thing. So in this case, in this the case of stroke, it's a no. So it will be a no because the outcome, which I will show you right now, outcomes include door to needle time, door in, door out time, and lastly, the clinical outcomes include composite of walking independently, and the lead one includes symptomatic ICH, in hospital mortality, or discharge to hospice, right? So now the only way this could be included is that if I'm assessing for the composite of walking independently, but then again, this is at discharge. right? And then lastly, of the discharge to a hospice. Okay, so if the patient had come from hospice, then I would click a yes here. Or if the patient was like, um, already walking independently at discharge. But the problem is that I'm not assessing the risk of bias of only one outcome. Usually what we do is we, do the risk of bias for singular outcomes, but it's not recommended. Because if you do a risk of bias for all of these outcomes, like let's say there are 7 outcomes and you do 7 risk of biases, and then you have to combine all of them together, and that's a whole amalgam. So what we do is we usually ask the people to either assess the primary outcome, the most important outcome, which is the primary outcome, or in such a case in which there is no primary outcome, we do the risk of bias of the whole studies. And since majority of the outcomes were not present, I'm going to click a no here. Then we go for the comparability. Now, this is the comparability on the basis of the most important factor and then any additional factor. So what we're going to do is we're going to once again search control. I'm not seeing any controls. Then I'm searching on cofactors. No cofactors, covariates. Okay. So this is our probability of favored outcome. This is the finding a relationship. The figure plots the relationship with 95% confidence interval. And this is adjusted odds ratio. The moment you see adjusted odds ratio, it's a sure shot and a definitive proof that they controlled for the most important factor. Okay, you should like just mark it as a 1 point without thinking anything else. Then we see that they were holding the covariates constant at their average values. They used age, they used NIHSS, they used glucose level, they used history of hypertension and all these significant cofactors, right? So the study controls for any additional factors there, of course it does. So that's a 2 by 2. And what I usually do is I write it like this. Okay. Then lastly, the outcome. So assessment of the outcome. The self-report, once again, no, it's like no good for us. If it's not described, that is like the biggest red flag. Now, for the outcomes, what you're going to do is you're going to go to the methodology section once again, obviously. So in the case of methodology section, both of these are like acute outcomes, which are measured right on the spot. So these are obviously like not going to need any additional things. The text that is written here is an independent blind assessment. This means that this is not assessed by the same person who was treating the patient. Now, obviously, someone who's treating the patient, they would want a favorable outcome leading to observer bias, or that's not allowed. And so if it has to be an independent blind assessment. For example, if the attending physician performs the procedure, another postgraduate trainee who is not on call with the attending physician should assess the outcome. Usually, this is not given. Usually, this is not given that the outcome was assessed by an independent person. The reason that I have understood in this case is that the door to needle time is not going to be assessed by the doctor. It's going to assess by the person who has either received the patient, the ER staff, or by the medical records, right? Sorry. So it's an understood thing that a doctor did not assess the door to needle time because he was in other procedures and he was doing other things. Now this outcome, composite of walking independently at discharge, this is done by doctor, right? Because obviously the discharge will be done by the discharge to home. This one is not done by doctor. So if this one was the only outcome or this one was a primary outcome in this study, I would have given a 0 because this is no way, there is no objective way to assess this outcome. The patient was walking independently. Okay, I understand that the patient was walking independently, but I'm sorry,
Yeah,
I will be taking questions at the end.
Basir, can you please mute yourself?
एक बंदा कंसंट्रेट कर रहा होता है तो बीच में क्यों
Basir, Thank you.
So anyway, the main thing is that this outcome, it's not a properly measurable outcome, right? So in such outcomes, what would you do? Then discharge to home, this is not a proper way to measure the outcome, but what the proper way is that walking independently in front of the doctor at discharge. So most people would include 1 point if it was only assessed by this, but this is the problem that's arising, because the discharge to home, we cannot, it will be reported by the patient, and the patient can simply lie. I'm not saying that the patient did lie. We are not saying that a patient is a liar, or that this outcome is wrong. No, the outcome is not wrong. We are saying that this outcome can be a potential for bias. That is the main thing. That is the thing that we have to assess. Sorry for the disturbance. Anyways, now we go to the follow-up time. This is an acute ischemic stroke. So the follow-up time which we do expect would be for all the recovery methods, all the recovery outcomes. These outcomes will not have a follow-up period. These outcomes, right? And they have not mentioned any follow-up period. I searched the article, and if you do not believe me, see, there is no follow-up period which was assessed in this study. They only mentioned the time from which it was conducted, but they did not mention to how much they did. Now some would argue that they mentioned this at discharge, but then they should have mentioned the range of discharge. Some people are discharged on post-op day 2, some are here for a week even, right? So how can we basically know? So that's a 0. I'm gonna give this study 1 here, or I'll actually, I'll select both of these, and but of course, like we can only give 1 point. Okay, we're not gonna give 2 points, because this whole thing is of 1 point, even if the study say ticks both of them. The follow-up, there was no follow-up, so no. And lastly, adequacy of follow-up of cohort. Once again, they did not mention any follow-up to the study, or to the patients. So I cannot score it. One more thing is that you can search attrition. Attrition bias is a loss to follow-up bias. So if they have mentioned any sort of attrition bias, we can maybe see something, but it's not, because they did not. I don't think that they adequately followed up the patients as well. One thing that we can do is we can search lost, and it would show us the loss to follow-up. And if it haven't shown us anything, we can also search discontinue, but this is usually in clinical trials that the people they discontinue the trial. So that's loss to follow-up as well. So in this case, no statement. 1/3. This study was very well performed, but the outcomes, since they were most probably due to them being in routine clinical practice, they could not be assessed properly. So in this study, it's 1 plus 2 plus 3, it's a 6/9. This is how you do a Newcastle Ottawa scale. I hope all of these were okay. If you have any questions, you can write them down in the chat, or you can write them down right beside you, and we will answer each and every one of them at the last. I will not let any question go unanswered. Don't worry. Okay. Now that we are done with Newcastle scale, let's just close it as well. Obviously, also you don't have to worry. I'll give each and every one of these, documents to you. I'll send each and every one of these documents. Don't worry. Now we will go to our complex ones. I'm going to go to Robbins E. Now these are the best, critical appraisal tools which are developed. Let's try this one. Let's try a new study. The problem with actually, you know what? We don't have that much time, so let's try this one as well. It's already 1 hour, so I'm gonna do the article that we are familiar with. Okay, so now this one is also for exposure trials, or or sorry, exposure studies or observational studies. The one that I showed you before, that one was also for exposure studies. Which one do we use? This one. Obviously, this one. This one is like way better. Let me show you guys. This one is like very much better than that Newcastle-Ottawa scale. When you're starting out the research in the very beginning, okay, it's completely acceptable to, hmm, you know, not use this Robbins E tool. At first, start with the Newcastle-Ottawa scale. Perform it 2-3 times. Perform it 4-5 times, maybe even 10 times to get a very good grip on it. Then move on to this tool. Okay, this tool is the standard tool for doing this. While starting for this tool, you have to say that the authors make any attempt to control for confounding, which they did in this article. If they did not use any attempt, you're similarly going to make the risk of bias high. For that study, see, this is the thing which is very you know tough in this one, is that this is this is a stronger or a tougher checklist. This checklist scores more critically, it assesses the study more robustly, and it has this checklist has very low human error or very low human bias, but it still has human bias. There are other checklists which are better than this one for clinical trials that I will show you in hopefully 10 to 15 minutes. Now, this whole Robbins E, also known as the Cochrane's tool of risk of bias in non-randomized studies of exposure, ROBINSE, Robbins E. In our study, the authors did make attempts. Since we have done this as a Y, actually, you know what? Let me just, yeah, Y. We did do this as a Y. So all of these are not applicable because all of these questions are due to this one being a no or a probably no. As you can see that Y is yes. Sorry, actually it's not written here. It is written in this document, but I don't remember where it is written because I've been using this so much that I already know what. Yeah, here it is. A simple Y means yes, which is the best. Okay. So py means probably yes. I would say yes. The thing which was uncertain, but you were more on the yes side, you do py. P and probably no. You're like, I would say no. Like you're not sure, you're doing this and this and this, but it's a no. And lastly, the no, this is like complete no. And the not applicable is for those questions which are like guaranteed to not be included or not be relevant to this study. Okay. So there is no uncertain here. There is no mid ground here. It's either yes or almost yes, almost no, or no. That's how it's gonna be here. Then secondly, was the method of measuring exposure inappropriate? No, all of the exposure was measured appropriately. We administered drug in front of us. Why? Oh, sorry. And inappropriate? No, it was not. Was the method of measuring the outcome inappropriate? Probably no. Why? Because there was one outcome, the walking one, which I was not satisfied with. All the other outcomes I was. Initially, these tools are made to assess the outcome of just one. For example, door to needle time, or door in, door out time, or independent walking time. But since it's gonna make an amalgam, it's gonna make 6 to 7 critical appraisal lists. Now, obviously, the recommended thing that I would recommend officially is that you have to assess each and every outcome individually. This is what I do assess, but I know it's not practically possible. I have a study with 8 outcomes. So, and I have a study with 8 outcomes and 15 clinical trials, like RCTs included in it. So that means that if I use each and every study for each and every outcome, and trust me, it was like each and every study was present in at least 5 or 6 outcomes. I will doing these checklists 75 times. That's not possible. I mean, it is, but not appropriate. So we usually do for a study, and we report the data in the form of a study. Okay, so I thought someone was speaking. Anyways, now this is like describe the exposure measurements used to produce these results. Once again, you're going to be commenting on the exposure results and etc. etc. Just skip this part and skip this. Like obviously you have to fill this one, but it's not important for assessing the our risk of bias. Okay, so now we go to this part, the complex part. See, this is the whole checklist that we're gonna fill, and I'm gonna make it easy for you. Don't worry, don't worry. I am going to make it easy for you. It's going to be very easy. Okay, so first of all, did the author control for all the important confounders? Yes, they did. Right in front of us, they did. Were confounders that were controlled for measured validly and reliably? Okay. Now I'm going to this study once again, and I want to see how did they measure the let's say NIHSS. Like obviously NIHSS scale is measured by the scale, so that's appropriate. The age is also appropriate. Let me first of all see the cofactors, covariates. Hmm. The study is glitching. Give me a minute. Okay, so we have dyslipidemia and diabetes. Let's see how dyslipidemia was done. Okay, so did not mention it how dyslipidemia was done. Diabetes, they did not mention how diabetes was done, right? So we have like two outcomes which were not measured properly, and the rest of the three outcomes which were measured probably, which were measured appropriately. Probably why? Probably they did measure it because they didn't like show us of the measurement of two of these outcomes, but they did tell us about the other ones. So probably yes. Now, did the authors control for any variables after the start of the exposure period being studied that could have affected by the exposure? Right? Since this is an acute study, okay? This is an acute study. The authors cannot properly control for any variables after the start of exposure because the exposure period is just a couple of, not a couple of, but still like a few minutes, or maybe if it's complicated, a few hours, right? If it was a long chronic study, then I would have seen that where they were, during the progression of the study, were they controlling as well? Since this is the study which it doesn't apply to this, not applicable. You will not select a yes because it isn't applicable. You will select a not applicable. Did the use of negative controls or other considerations suggest serious uncontrolled founding? No, it didn't. Like as we can see that here it is. Actually, no, here it is. Yeah. And if you see that in these patients, things are essentially similar. The age, almost similar. The gender, 52, 62, 51, 67. Like in the alteplase, it's 52, and the other one is like in the 60s. Now, you can say that it comes, like its p-value significant, so it is a bias. And I would say yes, that, okay, to some extent, this is a bias. Race, once again, not significant, right? And then lastly, I think this one is significant. What's this? This is a glucose level. The glucose level, it is significant. And they like, most probably they did diabetes via or BSR or blood sugar random, most probably, or HbA1c. Okay, lastly, the system, like all majority outcomes are not imaging type. It's like it's not a cofactor for this study. So did the use of negative control or other suggest serious uncontrolled foundings? Probably no. I'm not sure because it did. because it did give us some, values which were significant, but not every value was significant. So, which is why I would say that probably no. And then risk of bias and estimated exposure on the outcome, right? Right. So now we're going to use a low, some concern, high, or very high as a general measure. As a general measure, if any of these are unfavorable, now you see that y or py is favorable. Here be y, py is favorable, and in this one, y, pn or n is favorable, right? Right. If you have any single red in this part, a single red, one red, you're gonna click some concern. Okay. If there is no red, you're gonna click low risk. If in this part there is all of them are, reds, or so sorry, like all of them, two of them are reds, you're gonna click high risk. And if all of them are red, you're gonna click very high, right? So it's like 0 red, then 1 red, 2 red, 3 red, and then you go from low to very high. Okay, so this is how you fill these for each and every of the domains, right? So we have got domain 2, 3, 4, and all of them. It's going to take you, the first step is going to take you 2 hours. It is going to take you 2 hours. Like I personally did the ROB 2.0 for a randomized control trial, an RCT. It took me 3 hours and 15 minutes, around, I think 15 or 20 minutes, like 200 minutes to do single study, one study. And now I can do it in half an hour. So that's what practice makes you perfect. And to be honest, like at this point, I don't do them like myself. I teach the people and I teach the juniors, and then I do them and I tell them how to do it, and then they perform it, because this is not something very, technical or very problematic. It's just time consuming. So I don't think it's like, a good use of my time. I could be handling the more technical or the difficult parts of the studies that I do with my juniors. Okay, so this is how we fill the whole form. Are we done with it? No, we are not done with it. Why? Because we are now going to go another place. We are going to have here. We are going to go to this tool, ROB VIS, ROB Viz. It's known as risk of bias visualization tool. Now, upload your data. Oh, sorry. First of all, it has all of these sets. What we did was this one right here, Robbins E, risk of bias in non-randomized studies of exposure. Upload your data. They also like give us a template. If you click on that button that I just showed you, it's going to give you this template right here. Now you see this study had 10 this meta had 10 studies, and it shows us all the 7 domains. Domain 1, 2, 3, 4. Each of these, like this one is due to post-exposure intervention. This one is due to selection bias. This one is most probably due to, measurement of exposure, like obviously the exposure. This one was due to confounding factors, right? So all of these, there are like 7 domains, and each of these domain assesses a separate part of the whole study. Now what you're going to do is you're gonna, like, for example, in our case, it was low risk, but in this case, the study one, it was some concern, then low, some concern, low, some concern, some concern, and then overall they said that it was some concern. Now, how to measure the overall? Okay, so most of these tools, they would have written here how to measure the overall in this one, right? This is the 7th one. And this one is the overall risk of bias. Now, low risk of bias in every of the ones, except for concerns about uncontrolled confounding. Okay. So each of the domains should have a low risk of bias, except for the first domain. If the first domain has some concerns, it's okay, no problem. But all of the others should have a low risk of bias. So if this study one was like this, we would have clicked it like this. Okay. This is how you see the overall low risk of bias. Now, the other thing is very easy. If you have any one outcome with a high risk, you select them as some concern. If you have more than one outcomes with some concerns, you select them like this. If you have any one outcome, which is usually this one with a high risk, you will select some concerns. If you have outcomes which have high in more than one, you will select it as high. For example, let's see, one high, sorry, too high. See, one high, too high. In this patient, you have 1, 2, 3, 4, 5 some concerns and a single high. Now, obviously, this is going to be high because all of the studies, they're like some concerns. And then you also have a high, so it's like a high. In this one, once again, you can see it has like two highs. This one has a single high, oh, sorry, two highs, and this one has a single high, but then again, it has like 4 some concerns. See, so a general measure of low is only D1 some concern. For some concerns, you will have some concern, only one high with all others low. Or, and of course, if you have like if you have some concerns in all of the outcomes, then obviously your risk of bias should be some concerns. In the high, you have at least, you have one high plus others some slash low or some slash etc. And or if you have more than one high. And lastly, in very high, you have either very high, at least, sorry. I think in very high, if you have at least one very high, it's going to be very high, if I remember correctly. So this is how you're going to select the overall risk of bias. Okay. And now I have to delete these because otherwise the software is going to produce an problem. Now we have this saved Robbins E example. I'm gonna go to this Robbins E, choose data file, desktop. See, it has like in front of us. Our data contains an overall volume, not a weight volume. Our data has an overall column. It's going to give us two plots. The first one is known as traffic light plot. See, it has green, yellow, red, and then the blue for no information. This is like red light, what do you say, right? Obviously like red, green, yellow. And this is the summary plot. This shows that in the confounding, in the first, domain, there were either some concerns or there was high concerns. And then one or two studies did not give any information. Then we have this one from here due to measurement of exposure. And all of these domains show you that overall, like how good or how bad was it. And this one would give us, like in the end, the final answer of the overall risk of bias. This is known as a summary plot. When you're writing the article, you can either add this plot or use this plot. You can do either one of them, or you can do both, like I do. I basically add both of them in supplementary file if it's a network meta. This one if it's a simple meta. I like this one. It's like prettier to me. So what you're gonna do is you're gonna click here, download plot. I'm gonna click here, download plot. Obviously, I would recommend PNG. This is the best way. You can also customize in the colors. This is for the colorblind friendly people, and this is the normal colors. Similarly here, colorblind friendly and the normal colors. Okay, this is how you make a plot of Robbins E. Now we are going to do Robbins I. The Robbins I tool is probably the least used tool I have in my experience. Never use the Robbins I. Why? because usually if it's a simple clinical trial, we just skip it. We normally include, how do I put this? Randomized control trials and network meta-analysis, and it's been otherwise, if I don't find the trials, I also include the observational studies. So then I use the Robbins E more. So like usually, if the people do perform a trial, they usually perform as a randomized control trial, and it's actually quite hard to find the phase 1 or phase 2 non-randomized trials in our clinical setting. If especially in my field of neurology, like it's very hard to find them, because either you're dealing with very chronic diseases which are like stroke, or other one would be like the sorry, the chronic disease which is like Alzheimer's, or the other one would be like acute disease like stroke. uh okay, so let's get to Robbins I. The main thing about Robbins I is that it is similar to Robbins E, but it is for clinical trials. So the questions will be a bit different, but other than that, it's like essentially similar. There is no proper, big difference between both of them. I'll just show you these. Where is it now? Here we go. I'll just show you this one, and I'll just compare both of these in front of you. See, the main thing that is different in this one is that it has algorithms, which I really like. See, this is now this does seem like it's very complex, or it's very hard to do or anything, but it's essentially similar to what I just did right here. See, in this we also had questions right here. We also have questions. The only problem is that the questions have a proper definition, because obviously like these are technical questions, so they have given us a very, very good elaboration. Okay, so once they've given us this elaboration, you will like obviously you will answer these right here, and or in front of them, like I usually answer it right here like this. I will just click on Y here. Okay. The main thing with risk bias is that it's a completely new thing. So like it needs a lot of information to for the person to have, and a lot of practice to have. And it at first it seems very boring, and it seems very frustrating. So don't worry. Okay, once you've answered all of these questions, then go here. Look at the algorithm. For example, the answer to 1.1 was probably yes, then you go to here. The answer for this was probably no, then you go forward. See? So this is like they just laid out a foundation for you, and you can just get to your correct answer like this. See, they've written each and every algorithm for you, so it's very easy to do. One more thing is that if you all that you have to do is you have to save this as a PDF. Okay, if you save this as a PDF, I'm going to show you a website that's going to help you a lot. First of all, you can just ask ChatGPT, what is WN in Cochrane's Robbins I tool. For example, I just asked here what is meant by NI, for example for you guys. See, it gives me the main answer, and then it also gives me the meaning. Similarly, if I search WN stands for weak, or no, probably no, weak, no, or probably no. See, it just gave us, and then it also gave us all the standard observations. So it's like very, very good to do. But if you're not understanding anything and you want to upload a whole PDF, this is a website known as chatpdf.com. You'll click here. You will, how do I put this? Let's add a complex one. I've added the
Sorry for
most complex.
interrupting, Dr. Fazan. I'm sorry for interrupting, but the session is getting a little longer. We have like a limited time of 1 hour, so if you can kindly wrap it up.
Okay. I'll wrap it up in 10, 15 minutes. Like this is the last thing which is remaining. Don't worry.
Okay, okay.
Yeah, okay. So I just uploaded a 72-page PDF in front of you. And now I'm going to ask you how to give me the algorithm for finding domain 1, which is due to randomization. Okay. Page number 20. See, here it is. Okay, so now how do I put it? Let's say that I am having a difficulty understanding this thing. 1.1. Can you explain the 1.1 point in box 4 a bit more clear? Now, obviously, this is a free version. This is not a paid version. So obviously, it's going to be making some mistakes, or sometimes not giving you the right answer, but you have to double check that everything that is going. Yeah, was the allocation sequence random? Was the allocation sequence random? Explanation. Here it is. Summarize and tell it to me in simple words. 50. While this one like loads, this is how, if you have any problem, you can upload any tool in the PDF form here and then assess the risk of bias according to this. Okay, now the last one is our Rob 2 for RCT. This one is actually like, the most toughest. I'll be very honest with you. This is the toughest. Why? Because this is for randomized controlled trial, RCTs. Okay, so now, while this is for RCTs, it's going to take some time because obviously I've asked it to do a very big job of explaining the whole point to me. Okay, it's not allowing me to, open them side by side, so it's okay. So see, this is the whole document, which is the whole manual, which explains each and everything right in front of you, right? But if I go here, this is the sheet. Now, the main the main way that you're going to fill this sheet is by this form, and then you're going to just check your summary. That's it. You do not have to do any of this. Okay, go to Rob 2 assessment form. This is going to, first of all, assessment ID. Let's just select one. Assessor Fizan. I am the first assessor. Study ID Murphy. Or in this example that I have done is Schmidt. Okay. Experimental is Safina. Comparator is placebo, PLC. And now this is like intention to treat. Like obviously you have to open the whole trial and see if it's in the intention to treat or if it's not. But I know in our case it was intention to treat. Okay, so this is like it is a cohort, right? Hattori. Yeah, it was by Hattori. Here we go. Okay. So now this is the one that we have by Hattori. You're gonna go here. First of all, first question, was the allocation sequence random? Was it concealed? And lastly, did the baseline differences suggest a problem? Okay, if you do not understand this question, double click it. It's going to give you the whole explanation. The same explanation which was present in this PDF. So it's up to you if you want to use the PDF, if you want to use the sheet. I use the sheet. Okay, so I just go to this study and I search for randomize. It's a randomized control trial. I know I'm going to go to the methodology and see this is a randomized, double-blinded, placebo-controlled trial. Once again, I go here. Was this allocation sequence random? You can either click this arrow or you can use Y. Yes, it was. Concealed, probably Y. I don't have the protocol, but it was probably concealed. Did the baseline differences suggest a problem with? No, or probably no, because it did not. If you go to its demographics, you will see that it's essentially similar. 57, 58, 63, 68, 67, 68, almost 8, 8.2, 8.5, 38, 45, 38. See, it's like essentially similar. Similarly, p-values, all of those p-values are like insignificant. Even this one is insignificant. So I'm going to go here, and then I'm going to select this one, and then I'm going to click on algorithm. It's going to automatically give me the answer, and it's low. And I click here and I see, yes, I am satisfied with the low. I'm going to click low and I'm going to click save. Then I go to domain 2. Once again, were the participants aware of the intervention? No, they were not. Were the carriers and people delivering the interventions aware of the participants? No, they were also not. Then, was an appropriate analysis used for the intervention? If I go here, if I go to the statistical analysis part, this is the statistical method. If you read the whole method, you will see that this is actually an intention to treat. The primary analysis was applied to the full analysis set. This is intention to treat analysis, which means that appropriate analysis was performed. So algorithm low, once again low. And then you're going to perform the risk of bias for all of this. I'm just going to do it for all of this. And then I'm gonna show you, save. Once again, domain 4. Let's say that probably no, probably yes. Okay. Oh, never mind. Hi. And then lastly, in this one, if it was, let's say Y, probably Y, not enough information. Algorithm, hi, never mind. Hi, we save it. The algorithm in this one is very tough. Okay. So overall bias, low, 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 high, high. Algorithm shows it's a high. I say that it should be high as well. Okay, but now if I go to this one, if I click here, probably no, probably no. Some concerns. And if I click this one as probably no as well, confirm no, confirmed no. I don't know why it's giving this. So for example, let's say it's only some concerns. Okay, we save some concern, we can click save. Overall bias, low, low, high, some concern. I say that it should be some concerns. It is some concern. The reason I'm saying this is obviously the algorithm is assessing it the way it's supposed to be, very, very tough. But what I personally think is that this algorithm is very tough, and most of the people, they would agree with me. If you have a single some concern, the algorithm would say that it's a some concern. The algorithm is a very, very non-forgiving in this one. So sometimes it's okay if you feel like all of them are low, and maybe this one was low as well. And if this one was probably no, this one was probably yes. This is high. Oh, sorry, this is low, low, save, overall bias. Now see, this is like low, 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 and a S. And I click here, it still shows me some concerns, but it's okay. It's okay if you have just a single yellow, you can do it low as well. It's okay to do this. But if you have more than one yellow, then you have to do it some concerns. Okay. So this is how you're going to fill the whole form, the 5 domains. Just like I showed you in all those examples. Then you're going to click close, and you're going to go to summary. And obviously in my case, I did so much changes that it had, it's going to glitch, but let's click on result sync and hope. Oh yeah, it didn't glitch. See, low, some, low, 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 and etc. etc. It has given me basically, it has given me domain 1, domain 2, domain 3, domain 4, domain 5, and then overall. Then I go to my files and I click on ROB2 example. This is known as risk of bias 2.0. It's like name is ROB2, ROB 2.0. Here I have all of these 5 domains, and the study one, the one by Hattori, had I think some concerns here. So it has some concerns here, and then I click here. I click Hattori. No, Nobutaka Hattori is actually a very, very well established scientist. So anyway, I just filled this one. I close it. I go to my tool, the RobVis tool. I go to home. This is how I downloaded each and did. This is a ROB 2.0 data for me. See, another one downloaded. Another way, I go here and I say that I want to upload data now. And I want to upload for the logins too. And I browse the file. has given me my file. I generate plots. And once again, it gives me hmm, 3, 1, 2, 3, 4, 5. Yeah. And I click on generate plots. Yeah. It has given me the plots.
If we can wrap it up in next 1 minute so that to respect everyone time. So
Yes, sir, sure. And so if you can see that we have completed the whole traffic plot and we have completed the whole summary plot. So you see that we have made both of those plots, and these are like the thing that you have to do. I've shown you for a randomized control trial, for like basically every study type, RCTs, non-randomized trial, observational studies of any types, and then case control, case reports, and cross-section studies. With that, the risk of bias topic is finished, and I know it's a bit long meeting, but the problem is that this is a very new concept, and I had to teach you from the basic, like start you from the scratch and then end it at the like highest level. So I hope you guys learned, and if there's any question, like you can ask right now or you can ask later as well. Thank you so much for giving me the time, and this is all from my side.
thank you so much for that. I think we have one question. It asks, I think from Raza, if we use assessor judgment here, then why use this scale to see the bias? I think. Sorry, you're muted.
Fazan, you are muted.
Oh, I'm sorry. Like, why do we use this, algorithm if we ever, or if in the end all that we're going to do is use our own insight. So this algorithm is basically used is the recommendations by the Cochrane, and the recommendation by Cochrane is that like if there's only a single sum concern, you have to use some concerns. But obviously, not everyone agrees with Cochrane. There are many experts who do not agree with them. So that's why it's up to you if you want to follow the Cochrane's guidelines or if you want to follow something else. That's why, like, it's up to us.
Great.
All right. Do we have any other questions? Right. So if anybody has any other questions, they can just ask them in the group, and Dr. Fazan will be available there to answer your queries. Well, thank
Yeah,
you,
yeah,
Dr.
exactly.
Fazan, for I was saying thank you for sharing your insights and teaching this topic in a very comprehensive way. It definitely made it very easier for us. Before moving forward, I would like to welcome and thank you, Dr. Marwa Khalid here. She was our chair for this course, and she did an incredible job in organizing and teaching. Thank you, Dr. Marwa. I believe that you would like to say a few words in our concluding session
Uh,
here.
Yeah, thank you so much, Dr. Ataurahman. It was such a incredible session, Dr. Fazan. You have like explained it very well all the way from the scratch until the end. And thank you so much, Dr. Amir, Dr. Ataurahman, for moderating, and Dr. Amir for providing us this platform and all. And to all the people who have like joined us and till here, I hope you all have learned something from it, and I hope you all will perform a meta-analysis, and I will like to know if you will like publish a meta-analysis of your horse. So over to you, Dr. Abhay. I think you wanted to share something.
Yeah, thank you so much. Faizan, can you make me host so that I can share? I have like 7 slides, which is
Yeah,
just
yes,
like
sir.
not research based, but I think those are important things to consider. So if you can make me host, I can share the screen.
Yes, sir. I'm making you host right now.
Sure.
Can you kindly confirm, sir, if you're the host now?
Yeah, thanks.
Thank you.
All right, you guys see my screen here? You guys see my screen?
Yes,
Yeah,
sir.
we can
Yes.
see it.
Okay. So yeah, thank you so much, Faizan. That was fantastic review. I know it's very challenging for the like even for me, even like I've never did it to be honest with you. It's like the students sometimes they do it, and my colleagues who are very expert in this they do it. So it's really I think great. So I just wanted to like share top 10 challenges based on my experience of last 7, 8 years with all of you who are beginners and for the folks who will watch it later. I'll just take 7 minutes or so, and then you guys are good to go. The first challenge is I think it's very tough to start as an individual in research when you are now that you have completed 5 sessions. This is all you are going to learn in each, in anywhere you sign up for a course, you're gonna learn this thing. But once you learn the skill, the basic, I think, thing is like you have to work as a team. Select a good team on which you're going to do a project. You cannot do research on your own single person. You cannot. You need a person who is really good above you, and you are a part of a team where everyone wants to work. So that's the first thing. So never assume going in research that's by yourself. It's not a solo flight. You have to work as a team. So that's number one. Number two is like I hear from like many of the students that I'm lagging behind on my commitment. I think the problem is like students overcommit. So always, I think the solution to that is like always undercommit. That's the solution. But over deliver. Once you undercommit, you're on ease on yourself. You're not rushing too much, and then you're delivering more to the projects, and your mentor is happy and you are happy too. So it's very important to learn to say no. It's one of the most, like, for me, I think in the past many years I struggled with it, but then I come to realizations that making the commitment which you can fulfill, it's important, but do not make too much commitment which like it puts you under pressure. So that's number two. Number three is like once you do all of these things, then you really need. I hear a question that I lost the direction in career or in doing research or in a project. It can be any lost. So I think the most important thing that students do not realize is the having a mentor. That's extremely important to give you directions, to give you hope, and because research is boring. I mean, I'll be very honest. I mean, there's no like sugarcoating here. So, but once you do a research and you get the taste of it, then you really love it. Once you go to the conferences and all that, that's where you build up your profile. In all of these things, your mentor can really give you a direction. Important thing is you have to choose a mentor where you want to go to that stage. I mean, there are different kind of mentors. There's a whole lecture on mentor that we can give, but that's the thing. Number four, students ask that this is too much to do for me. So like, how do I keep a balance between all these things? So it's important that you're realizing it's too much. That's number one. Solution to that is like, as I said, there are multiple factors. Do not commit too much. If you have, I think the key is prioritize things. What is the most important thing? Like number one and number two and number three, prioritizing like a triaging, like if you are in a residency and that's how you get 5 pages instantly, stat pages, you have to see patient, which one you're going to tackle first. So first of all, definitely a patient who is going to die, and then the least thing is the patient who needs melatonin to sleep. So this is how you triage your problems life too, and in career. So that's the important thing, triage. To triage and to I think most of the number five challenge is like to complete a project. People feel like lost in a project. I think there are multiple factors, and the most important factor is team leader, who is, if you are assigned a team leader, then it's your responsibility to set the expectation clearly from the day one. It's your responsibility to choose the right person and give the assignment to the right person. Because if you're giving the bias assessment to the person who has never done it, it's unfair. It's not that the team member does not know, it's unfair. It's up to the team leader that he should know or she should know who to give and what to give. That's very important. So a team leader knows who does well. And then if there is any trouble, then he or she tries to jump in and help. And then a good follow-up time period and setting up it like a deadline is important from the team leader. So team leader is really something, when we do see a project, it's important. What we see is like, were you a first author? Because that would tell the program director that were you like, how are you as a team? Did you started and completed a project? So the research is not basically itself research, what you get out of the outcome. It's basically, it's your professionalism, it's your, communication, it's your time management, it's your teamwork approach. So there are these factors that we kind of like an ultimate product in yourself that kind of like it shapes your personality. Number six is if you think that you are so much, occupied, then how you can be efficient. So again, I think the key is setting yourself as a triage list every day and then month or a year or so, and then prioritizing it, define what you can. In all of this mist, don't forget yourself, take care of yourself, and then I think it's important to keep, like yourself as much at ease as possible. Don't rush too much, and don't stress too much. The team leader, one thing I would say is like delegation is so important. Like if I know how to do a thing, does not mean I will do it. The important thing is like if Marwa knows how to do the meta analysis, if she assigns a person who partially knows it and helps him or her, that is important instead of doing everything on her own. Okay, so that's the important when you reach a particular stage. It's exactly the same thing. If you know how to do does not mean you have to do it. Because how are you going to empower your team if you don't give them the task? I mean, some team members would know all, some would know partial, and some would know nothing. So you really have to have that emotional intelligence and to really figure out. And that's also part of the first meeting to really get their sense when you start a project to really see how much they know and what their capabilities are so that you can assign the tasks. So, but anyhow, time management is the key. And usually what I do is like make a checklist of my day or a month or so in terms of priority. And then I keep doing little by little. You cannot do everything together, but just do small little by little every day. I think that's the key. Number seven is like I hear from students, like I'm far behind than others. I think there's a lot to talk about it, but I think you are on your own. I mean, you care about yourself and no one else care about you. That's the fact of life. I mean, that's the like naked truth. Okay. And I think everyone has to go through sacrifice, but the definition of sacrifice is different for everyone. And everyone feels that their problem are the biggest problem, and that's the fact that because that's the person. So, but without sacrifice and without pain, there's nothing, there's no gain in research. I know so many people like one of my friend who was going from unmatched to psych. He went all the way into medicine, into cardiology, into intervention, like that kind of a track. Like from going unmatched and going into that kind of a track and that to that track. So all because of research. So research is extremely, I think, helpful for the folks who are having like difficulty in like filling up like any kind of like either it's a deficiency you say, or if they want to improve or shine more. There are people who have really good profile and they want to make it more academic. And I can see I even like really like the people who have less scores and more humble. I really like those people because I've seen people gets too much selfish when they get like really high score and then they think they are god or something. So I think humbleness is important. So number eight is this is important thing in research. If you have an abstract, like some people will say I have like 50, 70, 80, like there's like kind of like tons of abstract. As a program director, I mean, it would be fine as at a residency level, but in fellowship, what we do see is like how many manuscript we have published. That would tell us the quality. As Steve Jobs says, quality is more important than the quantity, and that applies to everywhere. So I feel like your manuscript is what this entire exercise of phase one was about manuscript. I mean, you can do like abstracts like really easy. That's a very easy thing to do. But main thing to do all about of it, it's like what your quality of work is and what you are doing and why you're doing. That's an important thing to do. Second last thing is like if you think like if I can't keep up over the weeks to months, I lose my motivation. So walk slowly is fine and do a little, but do it every day. I think that's the key. Persistence is nothing great comes like just suddenly. It's not a light switch you turn on and turn off. It's like a small steps that you take every day. I think that makes a difference. As Abraham Lincoln says, walk slowly but surely. So the last thing is when you reach a stage, I think the most important question you have to ask yourself is, can you help anyone? Or you are a person you say, go hell with everyone. I'm just on my own. So you have to really, I think, find a balance where you can, try to help others. I mean, this was one of the, or like my, like, advice. I mean, I'm like not a perfect person, but I would say it's important to ask that question to yourself when you reach at any stage where you can give back. So at the end, I want to thank these great people, course director Marwa, course coordinator Atar Rahman. They did a fantastic job and like really coordinating and communicating all these things in the past 1 month to complete this phase one. Our esteemed speaker, Dr. Marwa, Dr. Saad, Dr. Hamza, Dr. Jawad, and Dr. Fazan. They have been really amazing. This course is available on the YouTube. We have shared the links with you, so you can go back and listen anytime. It's freely available. So with that, I think I'd stop here. If you have any more questions, I'm happy to answer.
Right. So I don't think that we have any questions, but I want to thank you for the advices that you just gave. I think that they were pretty solid advices and were not only applicable to research, but also applicable to our other areas of life, especially when you spoke about try not to overcommit, try to undercommit and deliver, working as a team member, delegating your tasks, and not comparing yourself to others, and trying to help others, try to lift others as well. Those were some great advices. Um, with that, I think that, just thank everyone, especially Dr. Fizana as well. I think that you really dove deep into the topic, dissected it in a very good way. It made it very easy for us. I'm sorry to our participants if you felt like that it was rushed at the end. But Dr. Fazan, he was able to complete his lecture. We just like couldn't take any more questions, and you're always welcome to ask any questions in the group. We would be more than happy to answer them over there. Um, Dr. Amir, would you like to say anything else, or we just wrap it up now?
God bless everyone. Thank you so much for
Okay.
Yeah,
I would,
Pakistan's in the world.
yeah, indeed.